Hi, everybody, and I am just so happy to be here with you today talking about something that I am very passionate about, end-of-life care and death with dignity in particular. I so wish that I could be with you there today. With COVID and the world just being all up in the air as it is, I decided not to be up in the air in terms of flying and come to you safely from my office here in Portland, Oregon, where it is rainy and overcast, as is the case this time of year. But again, I'm so pleased to be here and pleased to talk to you today about death with dignity. I wanted to give you just an overview of who I am, and it was a fabulous introduction that I got there. But I just wanted to dig in to be a little more in depth about some of the things about me. I'm a social worker by training, and so lots of things that you will hear today are really sort of at my core of who I am in my profession. And I have been an end of life care social worker almost my entire career since I got my MSW. So I have very close ties to hospice, and I got my MSW from the University of Iowa in 1997. And very much after that, I spent most of my time with people who were dying as their social worker. And then after I got my PhD, I actually went into more policy work. So now I work with legislators and lobbyists and grassroots activists and grass tops folks and the whole gamut, governors, lobbyists, I'll say that again, doing end of life care policy work to make sure that we have the type of end of life care policy that we need in this country. Um, some other pieces about who I am and what brought me here today. I have a PhD in social work and social research from Portland State University here in Portland, Oregon. And for those of you who don't know Portland State, it's a university much like UMKC in Kansas City. It's an urban university. It brings folks from all around. It's a big, sprawling, beautiful campus. So if you know UMKC's campus, Portland State is very much like it. They're schools that are very, very similar. And again, my PhD is in social work and social research, so it sort of marries that individual level work with people who are dying with a social research lens. So looking at big data sets and numbers. I'm not going to dig into statistics today and chi-square and standard deviation and all those things, but I can answer those questions if you need me to. I'm a fellow in HIV prevention leadership at the CDC. And so I have, while I am a social worker, I have very deep public health roots from my time as a fellow at the CDC. And then who I am personally, I'm a cyclist. I've done RAGBRAI in Iowa, the big long bike ride. It was canceled this year, but I really wanted to do it. So I'm very much a cyclist. I'm an urban farmer. Right outside my window here, a little itty bitty urban flock of chickens that we have eggs every day. My art in my office sort of reflects the urban farmer that I am because I'm an Iowan. And, I have strong Midwestern roots, and it's one of the reasons why I wanted to speak with you today is because I wanted to come back to the Midwest, which did not happen. But I do have those ties. I've been with Death with Dignity professionally for about 15 years. And again, so almost my entire career, I've been doing this. And then the last thing I will end on is, again, I wanted to be there with you today because my daughter lives in Kansas City, Missouri, but alas, it's not. 2020 was not going to bring us what we thought it was going to. So let's talk a little bit about Death with Dignity and just sort of, some of you may know a lot about it and some of you very little. So I'm going to spend quite a bit of time here really getting us oriented to what is Death with Dignity and what exactly is the process. So Death with Dignity has a lot of names. It's Death with Dignity, physician hastened dying, physician assisted dying, medical aid in dying is the term that you hear most often in terms of what is the medical practice. So again, that's medical aid in dying, or MAID, as you will see it if you do some research. I call it Death with Dignity That's what it was named in the original piece of legislation in the United States that was passed in Oregon in 1994. So that's what I call it. But I'm talking about all of those things when I'm talking about death with dignity. So what is it? It's a state policy. It's a state enacted law, so state by state. And there are 9 jurisdictions with these laws, and they are Oregon, Washington, Vermont, California, Colorado, the District of Columbia, Hawaii, Maine, and New Jersey. And what the policy is a safeguarded process for patients to follow in order to become qualified to receive a prescription to hasten death. And it provides guidelines for physicians and pharmacists to follow in order to prescribe and dispense life-ending medications. So essentially, if you pull up the Oregon Death with Dignity statute, or the one in Washington or Vermont or Colorado, California, DC, they all look very similar. And you can read them from 1 or 2 lenses. One is, what are the steps that a patient needs to do to become a qualified patient to receive a prescription to hasten death? And then what are the steps that a physician has to do in order to prescribe? And that's all the Death with Dignity Act is. It's rather long, but it is very much just the steps from the patient point of view and from the physician point of view. At its core, the Death with Dignity Act in every jurisdiction is a standard of care. So it's what physicians need to do in order to prescribe if a patient requests a hastened death. It's exactly what the law is meant to do. So what it is not, there are many things that people talk about that Oregon Death with Dignity is, and it's actually not those things. So it's not euthanasia, which is typically when a physician would inject a patient to death. And euthanasia is criminalized by all of the death with dignity statutes in the country and through various pieces of self-standing legislation around the country. So euthanasia is not lawful anywhere in the United States. In fact, it's unlawful in most jurisdictions in the world. This is also not assisted suicide, which is criminalized by all the Death with Dignity Acts in the country. So this is not an act of a physician injecting a patient to end their life. This is a patient self-ingesting or self-administering medication to hasten death under really narrow circumstances. And we're going to talk about those circumstances a lot today. And death with dignity is also not suicide. So people who use death with dignity want to live, but they're dying. They don't have a choice. They're already dying. And so the choice that they are making, the option that they are taking, is to control the timing and manner of their death. But their choice to live has already been stripped away from them by their diagnosis, their prognosis, their disease, which is most frequently cancer. So death with dignity is an option at the end of life, but it is not euthanasia, assisted suicide, or suicide. And I will say, just as a social worker who's worked with many, many, many patients who have opted to use death with dignity, they have said to me over and over, this is not suicide. I'm not committing suicide. I don't want to die. I'm going to die. Right. And so, their pleas to me very much demonstrate that they're very different from a suicidal population that is living, could continue to live, but doesn't want to do so anymore. These are very, very different populations. So what are the underlying principles? So again, sort of when I think about death with dignity, or I think about pieces of legislation, because I said what I do mostly is policy work, I also teach policy work to social work students around the country. So when I think about a state law, I think, what are the underlying principles? Like, what is this legislature trying to accomplish when it passes a law? So the underlying principles related to death with dignity are autonomy, self-determination, dignity, non-abandonment, and the respect for the patient and the physician relationships. So again, if you think about those principles, autonomy, self-determination, dignity, non-abandonment, respect for patient-physician relationship, you're really getting to underlying principles in end-of-life care in general, in hospice, and in fact, I would argue in medical care in general. So really what this statute does is it brings together those ideas and sets a process to them. And again, these are ideals that very much are important to me from my hospice background, from my social work background. How do we make sure that we honor a patient's autonomy and self-determination and offer them as many options as they can, especially when they're dying? Because when you think about when people are dying, their options become closed to them and closed to them and closed to them. So what Death with Dignity does is it opens up the options at end of life just a little bit. We want to talk about dignity and non-abandonment. And what I mean by that is the physicians in the room or those who work with physicians understand this concept that what happens when a patient requests a hastened death, and the concept that a physician will not abandon their patient. So very much this principle of non-abandonment. And then Death with Dignity is all about the relationship between a patient and physician. Everything about the statutes that are existing are about this relationship. So again, these are the underlying principles related to Death with Dignity. And then sort of like after I think about principles, I think about concepts. So as we sort of get from the broad, right, to the more specific in terms of Death with Dignity, Death with Dignity is a patient-controlled process. So that means that nobody else can do it for the patient. Someone can't request on behalf of someone else to have Death with Dignity. Again, I mentioned earlier, there's no injections, like a physician cannot inject a patient. It's a patient-controlled process. The process can stop anytime. Once a patient starts the process, they don't have to continue. So at every step, this is a patient-controlled process from beginning to end. And again, another underlying concept is self-administration. And I mentioned this earlier, this is very important. No injections are allowed, no euthanasia is allowed under any of the Death with Dignity Acts across the country. And another underlying concept is there's choice for all participants. So the patient can opt to use Death with Dignity or not. The physician can opt to write a prescription or not. The physician can completely opt out. And in fact, healthcare institutions can opt out. Entire healthcare institutions can say, nope, we're not doing this. On our premises, we do not believe it's the role of medicine or it is inconsistent with our values. And so we will not allow this. So that means that for everyone involved who could potentially be involved, there is choice. Pharmacists do not have to fill the prescription if they do not agree with it. So there's choice for everyone involved. Death with Dignity is a prescribing only law. So what it is again, I talked about all of the steps that the patient has to go through and all of the steps that the physician has to go through. This is a prescribing only law. There's not another vehicle to induce death in a patient. It has to be prescription. And again, I talked about the underlying kind of idea that this is a medical standard of care. So what we're trying to do is give medicine a series of steps that it has to follow if a patient requests a hastened death. And we're shining a bright light. I think of this like what we're doing is we're providing a state sanction or a state oversight saying, if you're going to do this, because the research demonstrates and has for a very long time, the research demonstrates that physicians help their patients hasten death in all 50 states, in all jurisdictions, all the time. And so what this law does is it says, if you as a physician are going to do this, this is how you're going to do it. You're going to follow these steps, and we're going to highlight and tell you what you're going to do and set out parameters. So there's no loose cannons. This is a very, very narrow practice. So this establishes a medical standard of care. And it uses legislation to define who qualifies, and it uses legislation to protect vulnerable individuals. So if we think about what is a state's role in passing a piece of legislation in general, just conceptually, a state's role is to, grant something to someone over here, while at the same time protecting everyone else. So harming no other individuals, no individuals. And so Death with Dignity strikes this balance very, very well. It uses legislation to define who qualifies, but also uses legislation to protect vulnerable individuals. And it sets a very good tension. The laws that are existing are very successful in making sure that the state is able to provide something to this group of individuals while at the same time protecting vulnerable individuals using a series of safeguards. So I just want to step back. I have 3 patient stories to share with you, and I just wanted to step back and share one of them. I wanted to talk about a person named John who was 32 at the time, maybe 33, and HIV positive. And this was in the 90s. And his doctor said to him, "I will keep you alive as long as you want me to." And I was actually present in the room when the physician said this, and I was sort of taken aback. So take yourself back to the 90s, right? And think about medical care at the time, which it's very different than it is today in some ways. And so this patient, John, really, he wanted to live and he wanted to throw all of medicine at his illness. And he just worked very, very hard. And one of the things that happened is that he exceeded all possible expectations for recovery from multiple opportunistic infections. But this was HIV in the 90s. And so it was very clear that he was not going to survive as HIV is survivable today. And he enrolled in hospice, and he really received what I believe is sort of top quality hospice care in this country. He just, you know, from from the volunteer services to the medical services to making sure that his medical needs were met and his pain needs were met. It was top-notch care. But at the same time, his pain remained uncontrolled and his symptoms were intolerable to him. And he was really balancing the challenges of not wanting to be medicated until unconsciousness and experiencing the what was going on, but really having the pain be controlled. And he was actually a very spiritual individual. He was a choir director at his church, and he very much was very interested in thinking about what was going on with him spiritually and what was the meaning of his life, his death, his relationship to his God. All of those things were very important to him. And he really wanted to have the hospice chaplain there and his clergy there with him at the end of life. But it was really balancing this pain. And he begged his family to kill him. And I just say that just right out. I just say that he said, with all these things that were going on, excellent quality healthcare, excellent quality hospice care, really, digging into his spiritual needs at the end of life and his love for his family, which was very strong. He begged his family to kill him because his symptoms could not be controlled with modern medicine. And if you think back to that doctor saying, "I will keep you alive as long as you want to." The problem is when the patient, John, who was my husband at the time, when he no longer wanted to be alive because this disease was devastating his body and devastating him, the end wasn't near. And what came later was really bad and very, very, very difficult. And, that story is really why I'm here today, because I think it is so compelling that he very much had the best quality care that he could have, and still his symptoms remained uncontrolled. And he was dying, and what he wanted was to be able to control the timing and manner of his death. And it was so bad that he asked his wife, me, to kill him. And that was an action I was not willing to do. I did not do, but it did bring me to where we are today. So that's my patient story number one. It's a very personal one. If you meet people who are active in the Death with Dignity field like I am, many of them have personal stories to share with you about dying experiences, some good, some difficult, some very challenging, like John's story. Um, but I just am pleased to share that for you, to show you the passion behind what I do. So going back into my more academic world, how Death with Dignity works. So I've talked about these underlying concepts like self-determination and autonomy, and I've talked about principles like medical standard of care. But really, how does this work? And I'm mostly going to talk about Oregon, and throughout the rest of my presentation, I'm going to talk a lot about Oregon. But you should know that each of the Death with Dignity statutes in the United States is based on the Oregon law, and they're almost identical. And so what I'm telling you, if I talk about Oregon, it's practically the same in every state. So how it works, a patient makes a request to a physician and no other person can make the request. Again, this is a patient-driven process. The physician determines the patient is terminally ill with a prognosis of 6 months or less to live. If the patient does not meet that prognosis, then they don't qualify. The patient must then go through a 15-day waiting period after they make the oral request to the physician. And they must also in that time seek a second opinion. And that second opinion, that second doctor, who is called the consulting physician in the law, must confirm the terminal diagnosis and prognosis. So if this second physician determines that the person is not terminally ill within 6 months, then they can't qualify. After this second opinion, the patient must submit a written request, which is witnessed by 2 individuals. And then both the attending and the consulting physician must meet with the patient and have a clinical visit or 2 or 3, and must determine the patient is capable of making healthcare decisions. And if either physician, so either the attending or the consulting physician, believes that there's depression or mental illness or dementia or some other condition that is impairing this person's ability to make healthcare decisions, the patient has to be referred to a mental health assessment. And if that mental health assessment determines the patient is not capable of making healthcare decisions, the process stops. So again, it's very important in the Death with Dignity Acts to make sure that there's no mental illness going on, no depression, no dementia that is impacting a person's ability to make healthcare decisions. This is a very important part of the law. And so both physicians who are involved in the case have to determine that there's no impairment in health care decision making. And if there's any question, the person has to be referred to a third mental health professional, as a psychiatrist, psychologist, or a social worker with extended end-of-life care experiences to make the determination that the person is capable of making healthcare decisions. So say the person makes it all the way through that process, they've made their first request in orally, they have met the standard of a terminal illness with a 6-month time frame, a 6-month prognosis by both the attending and consulting physician. Both the attending and consulting physician believe that the patient is mentally competent. The patient writes a written request, and then what happens, and it goes through the waiting period, and then there is another oral request that the patient has to make. After all of those steps, and they're almost, again, identical in almost all the jurisdictions, so there's plenty of safeguards built into it. After all of those pieces to become qualified, the attending physician writes a prescription for a medication to hasten death, which the patient may or may not fill based on their choice. So typically, 1/3 of individuals who qualify do not ingest the medication. They go on to die of their underlying condition. The medication simply provides them peace of mind that if it gets bad enough, if the dying process or their pain are so uncontrolled, they have the option to ingest the medication if they choose to hasten their death. So how it works from a physician perspective, that was pretty much the patient perspective. And again, I talked about the Death with Dignity Act. If you just opened it up and looked at it, you'd have kind of one set is the patient, one is the physician. Again, physicians may choose to participate or not. So if you're a physician and your patient comes to you and requests a hasten death, the physician may say, nope, I'm not interested in doing that. And that is, it's done then. The physician doesn't have to do anything else. The healthcare system may choose to participate or ban the practice in their facility. So an entire healthcare institution may choose to participate or not. Typically, the Catholic healthcare institutions, which provides so much good quality care to individuals living in the United States, and frequently end-of-life care through the hospice programs, most, if not all, of the Catholic affiliated healthcare systems have opted out and banned the practice in their facility, which is allowed under the Death with Dignity Acts all across the country. And again, I'll just sort of reiterate that Death with Dignity legislation is a written standard of care guiding physician practice and protecting the physician, just like any other standard of care in medicine, that, to be protected from malpractice or tort claims, you have to follow the standard of care. And if you do that, you're protected. If not, then no, you're not protected. And again, I'll go back to this idea that this shines a bright light on the practice in the United States. I'll repeat, we know that physicians in every state help patients die every day. They hasten death, and they respond to a patient or a family's plea to end the suffering. This does happen, and it's not exceedingly rare. But what the Death with Dignity Act does is it shines a light. It provides a state sanction, a state oversight of this process, so that there are guidelines for a physician to follow. Also, I just wanted to have a nod to informed consent, because informed consent is a very important piece in the Death with Dignity Act. A patient or a physician must inform the patient of all treatment options for the patient's underlying condition. So say someone has pancreatic cancer, which is a common underlying condition that people would use Death with Dignity for, because it leads to uncontrolled suffering and a great deal of pain. The physician must inform the patient of all treatment options for that underlying condition. So there could be quite a few. And the patient must talk to the physician must talk to the patient about what will happen if they ingest the life-ending medication. This is really important. When we take a medication, we need to know what happens. So the physician must talk to the patient about that. The physician must counsel the patient to talk to their family members or tell their family members that they're going to do it. The patient doesn't have to, but the physician must counsel the patient to do that. The physician must confirm that the patient is not acting out of coercion or being forced to use the law. Some states have much stricter guidelines on that. In California, for instance, the physician and patient have to meet alone with not anybody else in the room. But very much the physician is responsible for making sure that the patient is not being coerced or being forced to use the law. And the physician must meet all informed consent process standards that are part of the standard of care in medicine. So the Oregon Death with Dignity Act and all the Death with Dignity Acts spell out pieces of informed consent, but also anything that is part of informed consent in the standard of care of medicine must be followed. So again, to review kind of the qualification process, we have a diagnosis of terminal illness with a prognosis of less than 6 months by 2 separate physicians. Both physicians must determine the patient is mentally competent to make healthcare decisions. Folks must be a resident of the state. And generally that's defined by the state legislature and confirmed by a physician. The person has to be adult, make 3 requests, 2 oral and 1 written, and go through waiting periods. Sometimes there's a 15-day and a 48-hour. Sometimes there's just the 15-day, but the waiting periods. So again, diagnosis, prognosis, mental health competency, residency, being an adult, 3 different requests and 2 different waiting periods. That's the qualification process. And so that's all of this, the standards or the safeguards that are built into the law. So just going through a patient story again, I just want to share a story of a patient that I worked with, I think about a year ago at this time, and he was in Portland here in an assisted living facility, and his name was Jasper. Wasn't born in the United States, but was a citizen, and he was 79. He was really not very healthy. When I met him, he had metastasized spine, liver, lung, probably brain. I didn't look at his medical chart, and he was unable to move. He was confined to his bed because the spinal and bones or cancer was really had really eaten away at his pelvic girdle, so he was sort of unable to move. And he wanted death with dignity, and he didn't really have the words for it. But he did want his physician to help him die. He was very clear about those words. And the challenge was his mental status was unclear to me. And again, I'm not a consulting physician, so I don't have to make this determination. But I am an advocate. But it was clear to me that this patient, I was not sure that he was going to qualify. But I did just want to sit with him. And so I sat and listened to him, and his wife had died, and his child had died too. So he was pretty alone. And what I learned was that he had pretty uncontrolled pain. And what was happening was that he was backing off of his pain medication so that he could, be engaged and talk to me. And then, taking it because it was so bad, because metastasized spine, liver, lung cancer is really painful. It can be incredibly painful. And so he was just going in and out of this kind of semi-consciousness and consciousness to really advocate for himself. And so I, in my role, he talked to the physician, and the physician, made the determination that there was a possible question of competency, the same thing that I had wondered about, and referred the patient for a mental health assessment. And during that time, I really talked to him about what he wanted. His death with dignity, his choice, but what are his other choices? And really what I learned was he wanted his pain to be better controlled, which makes sense, right? That's probably what most of us want. But it was, again, this challenge of being medicated to, unconsciousness or, being awake. And so really worked with his current physician. So he's going through the death with dignity process of getting a mental health evaluation. And then also kind of trying to control his pain and manage where he was living and how he wanted to die. It really helped him have a voice in the assisted living facility about what was going on with his medication and when he wanted to, be more sedated and when he wanted to be awake but tolerate the pain. And when we hit that balance, we hit that right sort of pain control balance, he stopped being interested in death with dignity. And I call that a success. Right? I just call that a success because he had this option. He considered this option. We really advocated for a whole host of options and came down to what he really wanted to do and what he really needed to live the rest of his days. And that's why I think this is a death with dignity success story. It has nothing to do with death with dignity. He didn't advance through the process. The safeguards worked, and but he got the dying that he wanted. So switching gears again, I have one more patient story that's lighter and faster at the end. I just want to talk about the policy process. So I talked about the physician steps, the patient steps, what death with dignity is, where it is. So death with dignity has been legal since 1994 in Oregon, where it was passed on the ballot, and it's the first of its kind in the world legislation. So we in the United States, there's a handful of jurisdictions in the country that allow physician-assisted dying, physician hastened death. Some allow euthanasia. So there's countries around the world that allow that. We have the most narrow and the most constrained legislation of its type in the world. So Oregon's law was groundbreaking. And it remains to be today. And to today, we have the most narrow and most constrained, again, legislation in the world. It's legal in Washington as of 2008. In Montana in 2009, there was a judicial order at the state Supreme Court determining that physicians could not be prosecuted under their constitution for prescribing a hastened death. So it's legal in Montana by judicial order. Vermont was the first legislature to pass in 2013, California in 2015, Colorado in 2016 by the ballot. The District of Columbia passed in 2016 through the city council process. Hawaii passed in 2018 through the legislative process. And just last year, both Maine and New Jersey passed the law in their state legislature. So 9 codified or, put into law pieces of death with dignity, 1 by judicial order in Montana. So the next steps, what are the next states that we see? The next states are the likelihood of passage is Nevada, New Mexico, Arizona. So that sort of west/southwest arena is really been very active for a long time and is really pushing toward death with dignity. We see Maryland has been active for about 6 years and is very close to passage. And also New York and Massachusetts are the big jurisdictions that are looking at death with dignity that I see in the next few years. 2021 is going to be a hard legislative year to call, clearly, with all of the things that are going on in our world, but very much death with dignity is coming to New York and Massachusetts. It's just a matter of when. So polling, it seems like a controversial issue, but the reality is that Americans support death with dignity. Death with dignity has demonstrated majority support in the United States in polling since the 1970s. Gallup, for instance, so let me tell you the question that Gallup asked. It has asked this question every 2 to 3 years since 1947. Right, so it's tracked. We have the polling data about death with dignity since 1947, and it says, when a person has a disease that cannot be cured, do you think doctors should be allowed to end the patient's life by some painless means if the patient and his or her family request it? And that current support, the latest poll, 2018, 72%. So when a person has a disease that cannot be cured, do you think the doctor should be allowed to end the patient's life by some painless means if the family and his or her, or the patient and his or her family request it? 72%. So again, you can question the validity of polls, that's legitimate, but the reality is it's the same question has been asked since 1947, and support looks like this. It started at about 43%, 40%, I think. It hit majority support in the 70s and is currently at 72%, sort of is tapering off at that 72, 73, 74%. Similarly, the Harris poll, which has asked this question for a very long time, national polling data, less frequently than Gallup, but kind of over time, Harris poll found, and the most recent one they did is 2014, 74% of American adults believe that terminally ill patients who are in great pain should have the right to end their lives. Only 14% were opposed, and that was up from 70%, so 70 to 74% between 2011 and 2014. Again, 2 different polling firms, different methodologies really come to the same conclusion that support for death with dignity hovers around the 70% line. So it's very, very much supported by individuals in the United States. When I travel the country speaking, which I do, overwhelmingly people tell me they support this. I'm in the airport, people ask me what I do, I tell them what I do. They're very supportive. It just is around the country. And again, this is a nonpartisan issue. I have supporters who run the gamut from NRA folks to libertarians, sort of government out of my backyard, to the most progressive progressives that you can see in the United States. And I have supporters who come up to me from all walks of life. This is not a partisan issue. We all die. We all have opinions about how we die. And so, and that's why I think that the polling is at the 70% that it's at. 70 million people live in a state allowing medical aid in dying. 70 million. So this is very much a proposal that is supported. State medical societies. So typically, organized medicine, the AMA, has been opposed to death with dignity, but the state level medical societies are moving so much now from a position of opposed to neutrality. And when we poll physicians, we see a majority of physician support on the issue. So very much. Sometimes the opposition to death with dignity uses physicians as the face of opposition. It's not true, actually. It is very much not true. The majority of physicians support this. And one of the things that just to think about in terms of support is we think about this as a sort of a contested political issue, but patients are resolute. Right? If this option is one for them, and very few people choose death with dignity, but for those they do, there's very little hesitation. Again, these folks are resolute. They know what they want. So in terms of implementation, what do we know about implementation in Oregon? And again, I'm going to talk about Oregon statistics, just a little bit statistics, but they're the same almost across the nation. In states that have death with dignity laws, kind of based on their population. So if you think about from 1998 to 2019, 21 years of writing prescriptions in Oregon, only 2,518 prescriptions have been written the entire time that death with dignity has been legal in the state. So this is a very rarely used option. 1,657 Oregonians have ingested a legal prescription dose of medication and died due to the Death with Dignity Act. So just 1,600 people, 1,650 people in 21 years. So this is a very rarely used option at the end of life. 51.9 deaths per 10,000 in the state in 2019. The Oregon Health Department estimates 51 out of 10,000 deaths are death with dignity. So what's the median age? Is 72. So what do participants look like? 96% of them are white. Oregon has an overwhelming white majority, but this is very much more than that. Again, the median age is 72 with a range of 25 to 102, but very much at the higher end of the range. Folks tend to be well educated. 43% had at least a baccalaureate degree. Overwhelmingly, this is a disease about cancer. 75.1%. It's also a disease about soft tissue cancers. That's sort of like you have to dig down into the data, but those cancers tend to be painful, difficult to manage, even with the best quality medical care, the best quality hospice care. 8% of folks had ALS, so that's a common underlying condition. Very few are 18 to 34 years old, so very much death with dignity mirrors a population of individuals who would have a terminal illness, most likely from cancer. So only 0.6% of them were 18 to 34, as opposed to 15.8% are over 85. It's split between women and men, 53% women, 47% men, but again, that's a split. Folks were well insured. So this is not an issue where people don't have insurance or don't have a way to pay for care. 98.8% of folks using the Death with Dignity Act had some form of health insurance. So again, they're getting good quality care. 92.6% died at home. So it's a very high rate of home deaths. This is very much about dying at home. 90.2% were enrolled in hospice. So again, some folks say that this is hospice or death with dignity. Not the case. This is hospice and death with dignity. So again, this is not a vulnerable group of individuals that doesn't have a way to pay for their health care and is not receiving good quality end-of-life hospice care. That is not the case. This is very much a group of people who are insured and are getting their end-of-life care needs met through hospice. And this is across the board in multiple states that have death with dignity, just not in Oregon. So I just want to kind of close on a patient story. I just want to talk a little bit about Gladys and her family. And this is kind of my story and my boss's story. Early in my career at Death with Dignity, when I was sort of jumping to a policy person, but really wanted to know how the process worked, because I'd again lived in Iowa, which is a non-death with dignity state. And I went to visit a colleague, and this colleague had been working with patients for about 10 years and working with folks who requested assisted dying and meeting with them. And I really didn't know what to expect. Kind of, I knew it academically. But I've been around people who are dying all the time through my work in hospice and um, other ways as a social worker, but I didn't know what to expect with this. And I was kind of shocked, I think, to find a room full of people and it's kind of surrounding the hospital bed in the living room as we see, with the lift chair in the living room, which we see. But Gladys, the matriarch, was in bed, and she was very old, and she was very physically frail, but she was very much in control of the room. And I met lots of people and realized that she had invited her family in because she was dying, right? And her kids and her grandkids and folks were there. And George, my colleague, stepped on her oxygen hose for a minute. I mean, there's just so many people, and it's kind of chaos everywhere, controlled chaos. And she laughed kind of from the corner, and she said, "So that's how you do it. It's the oxygen." And George was standing on the oxygen hose, and he didn't realize that what was going on, but he quickly did. And it was just funny. He's like, "That's how you do it." Um, and it just seemed like a very natural gathering of her family members, and suddenly like this experience of being with folks who are dying in other places, not using death with dignity, where they have gathered their family members around and they're imparting wisdom and making meaning of their life, right? That's our job at the end of life, as we really deal with our spirituality, our mortality, what's the meaning of our life, what do we mean to our children and our family and our loved ones. And I just knew that that room was full of love. And what I knew is that death with dignity is about life. It's not about death. It was about that life that was in that room. And I just realized at that time that death with dignity is just life affirming, and it was such an honor to spend that time with Gladys and her family. And death with dignity was the right choice for her. And she was dying, but she was going to control the timing and manner of her death. And there is just nothing that I could not have been prouder to help her have that choice. So with that, I think I will end this conversation with you all. I hope you've learned a little bit. If you have any questions, your conference conveners can help you reach out to me. But again, thank you very much for this opportunity, and I will perhaps see you another time. Bye-bye.